all so much, I really owe it to you. So I'm going to be talking about nipple discharge and genetics of breast cancer, two very varied things, but I think these are things that are going to be a large part of the story, especially genetics. In fact, as oncologists, we are also getting to hear a lot of genetics, and it is evolving as we speak. There's so much happening in that space. But I will start off with nipple discharge because this is something that you often see, and about 70 to 80% of women during their lifetime will come with this complaint of a nipple discharge. Usually nipple, and the other problem areas we know, mastalgia is a large part of our practice, but I think you see a lot of them as well because a lot of patients do come to you with mastalgia, with palpable lumps, and nipple discharge is a malady which, like I said, about 70 to 80% will come to. So let me just start off with some case scenarios of nipple discharge. So this is a 28-year-old, she's 6 months pregnant, and she's got spontaneous bloody nipple discharge of 15 days duration. And when you examine her, you find that there's nothing really to report except for multiple ducts discharging blood-stained fluid. And then you have a second scenario, which is a 50-year-old, and she's also got spontaneous bloody discharge of 15 days duration. But when you examine her, you find that there is a single duct which is discharging blood-stained fluid. And it is at, when you press at 6 o'clock, when I say 6 o'clock, you're pressing on the areola, and that is yielding blood. So these are two very different situations. So you have to look at them very, very differently. So let us look at what we would do in case scenario 1. So she's only 28. So when it's a 28-year-old with nipple discharge, you're certainly not getting a mammogram done. And ultrasound breasts, yes. And nipple fluid cytology has actually made its way out because oftentimes nipple fluid cytology does not contribute to your understanding of the disease, and eventually, so whenever I see a nipple discharge, if I were to tell the patient, you know, हमारे सब कुछ करने के बाद भी आपको सर्जरी की ज़रूरत पड़ेगी because I have to start preparing her for that eventuality because that is the only thing which is going to give you an answer. And in case scenario 2, she's 50 years old. So this is different. So, and she's also got spontaneous bloody discharge. Here you will do a mammogram, but you will also do an ultrasound because an ultrasound breast is one of the best methods of figuring out what is happening in the ducts. Again, nipple discharge cytology, no. Till about 6-7 years ago, this was happening, but now we don't do any nipple fluid cytology. So very, very important. Examination is very, very important. And your history is very important. Ask the patient, is it spontaneous or is it expressed? 80% of times it is expressed discharge. And expressed discharge, if I were to put all my might, and if I ask her, how did you do it? It is actually very, very gross. She's actually putting all her might to press her breast with, and I wonder, is it not hurting her when she's pressing herself so much? But if you were to press that much, any breast can express discharge. So express discharge is not of concern. And if you see a single duct discharge, also try to locate the trigger point. So it is a wonderful concept which whoever clinician thought of this is very, very clever because the ducts are actually converging onto the nipple, but it is taking the root of the areola, and if there is a duct which is filled with fluid, you touch the trigger point and press it, and it will express discharge. So that allows you to also figure out which possible duct is involved. So you must understand that in less than 10% of patients, if there is a blood-stained discharge, there would be an underlying malignancy. So it is not of a huge concern, but 10% is also not less. So you don't want to miss those 10% also. Age is an important predictor. With growing age, you know, the incidence of malignancy also increases. Cytology by itself, like I said, is of very limited value, and it is very, very low. 35 to 47 is hardly anything. So if you look at imaging, if there is a palpable lump, if there is something visible, mammogram has a high sensitivity. But if it is just a nipple discharge, and lots of times on mammogram, you will not pick up anything. But an ultrasound can pick up papillomas, it can pick up ductectasia, it can pick up malignant lesions which are very, very close to the nipple, which no other imaging can pick up. So ultrasound is a very, very important investigation. But if there is a visible lesion on a mammogram, it is very, very likely to be malignant. So that is how an intraductal papilloma will look like. You can see those arrows with those little excrescences within the duct. Those are the papillomas. And then you can just have duct ectasia with no papilloma. So you can see these nodules within the duct, but these could be debris which has got inspissated, and that also can confuse the picture a bit. But when you do a color Doppler on it, you will not find any flow whatsoever. And with the kind of high resolution ultrasounds that we do have, you can pick up things like microcalcifications, which was kind of restricted only to mammograms earlier. So the other important investigation which we all have heard and are hearing about is the MRI. But MRI should be reserved as a problem-solving tool. Unfortunately, we're seeing a lot of patients who are coming with MR mammograms as the first investigation. So that is not of help. Because once you've done an MRI and then you ask for a mammogram, कहते हैं mammogram तो हमने तो MRI करा लिए, but every investigation gives you a different set of information. Like I said about microcalcifications, an MRI will not pick up microcalcifications. It will not tell you about the extent of microcalcifications. For that, you have to do a mammogram. An ultrasound as a complement to a mammogram is a good tool, and MRI to be reserved only as a problem-solving tool. Sometimes with bloody nipple discharge, especially in younger women, you may want to do an MRI because there you're not able to figure out. And if you're planning surgery or something, you have to realize how conservative have you got to be, especially if she intends to breastfeed more children. So if you look at this breast, it is very, very dense, and she's got a very strong family history. Look at the ultrasound and you can see some microcalcification there. And here you're doing an MRI. This is a young patient, and it is beautifully demonstrated as to how the duct is enhancing. And an enhancing duct like that is by and large almost always abnormal. And these investigations that I'm going to talk about is kind of historical now because we don't use these anymore, whether it is ductography or ductoscopy. They came with a lot of promise, but now with all these advanced methods that we have, which is an MRI and all of that, we don't do any ductographies and ductoscopies anymore. But then when I was in the UK, there was a lot of talk about ductoscopies. We used to do ductoscopies. Very, very expensive investigation, but at the end of it, there is really no impact on the treatment. We thought that it would have a say in screening high-risk women. Even in that area, it has not really delivered. So this is what a ductography, very, very tedious and cumbersome procedure. We're going to cannulate the patient's duct and get the contrast injected and try to look at where the humps and bumps are, but did not really give us much. Ductoscopy is more like a bronchoscopy because there are multiple generations into which the main lactiferous duct would divide into the breast. So you can go on and see up to 3 to 4 generations of ducts with the ductoscope. It is very, very intriguing when you're seeing and doing it, but like I said, at the end of it, it did not really deliver on the promise that it was used for. So this is how it looks like. It does look like a bronchoscopy. So basically all like the endoscopic procedures, it looks very nice, but did not have much to contribute. So again, nipple fluid cytology, just to emphasize that it is not a reliable method of diagnosis. But if you were to do a ductal lavage, obviously that is also partly invasive because you'll be putting in a cannula and trying to aspirate fluid. That will give you more cells, and if there are more cells, it may make some sense, but we don't do that anymore because now we know that there are better ways to do it. So what is a significant pathological discharge? So it is single duct, single breast, spontaneous, serous or serosanguinous in significant amounts, and it has to have a pattern. It has to be persistent, meaning it should be happening twice or thrice in a week. If there is a one-off incident, say 5 months back, and then one has happened now, and then it is not happening for the next one, that's not very significant. But if it is bloody discharge or transparent, that needs to be looked at. Usually it is going to be an intraductal papilloma. But we have to rule out things like an intraductal carcinoma, meaning a DCIS, or sometimes even papillary carcinomas have to be ruled out. So when does one advise surgery in a case of nipple discharge? So if you look at if it is a single duct, blood stained, large amounts of blood on testing is persistent and it is associated with the mass, it is a new development in a woman older than 50. Possibly I would not even consider age anymore because we're seeing more and more of this happening in younger women. Then you should look at surgery. If she's of a breastfeeding age, then just do a microdecectomy. And if it is somebody who's completed her family, you may even want to consider a major duct excision. Multiple ducts less than 30 with serous serosanguinous are observed, with microdocectomy reserved only for those who have persistent discharge. Over the age of 45, don't worry too much. It's a small surgery. It is pretty simple. It is a daycare surgery. Get all those ducts out, because somewhere the disease begins in the terminal duct lobular unit, and we want to take care of that, that part also. And the 35 to 45 are suitable to either approach. Simple surgery, you put in a lacrimal probe to ensure that that duct which was causing the problem does certainly come out, and you bring out a conical bit of tissue like that with the probe in, and when you close her back, you can hardly make out that she's had a surgery at all. And that lady who was pregnant, bloody nipple discharge, multiple ducts, it is rather common, and it is not pathological. It is actually because of the ductal proliferation that happens and the hypervascularity, progesterone induced. That is the reason for it. You have to reassure her. And it happens actually into the first 2 to 3 weeks after delivery also. And the mother can get a bit jittery, considering that she's not able to breastfeed her child, because we don't want a lot of blood going into the child's stomach, which can be an irritant and lead to diarrhea and stuff like that. So that was my talk about the nipple discharge. दो तीन बार नहीं, अगर वैसे भी if somebody comes with a single duct discharge, even if it is not, but if you were to do a trigger point pressure and you find copious amount, that also is an indication for you to. Sometimes patients underplay it also, कि कुछ निकल आएगा, थोड़ा सा कम बता देते हैं. So don't completely rely on the frequency of it, but yes, if it is copious amount of discharge, you should still take it seriously. So if it is quite a lot of blood, then you should avoid. If it becomes white, then she goes ahead and feeds the child, no issues. Microcalcification is a big harbinger of malignancy. It is at least ductal carcinoma in situ, but it could be invasive also within the, it is in the spectrum of the disease, because next to your ductal carcinoma in situ is invasive carcinoma. And unfortunately, when you have a DCIS, it usually, it's a widespread disease. It is it's a segmental distribution. So you find that it almost occupies about 1/3 of the breast. So a lot of times we'll end up doing mastectomy for DCIS and conservation for invasive carcinomas, because invasive carcinomas are very, very confined. So we'll end up doing conservation. Irrespective. So what is happening is, when I'm saying DCIS, it is all happening within the ducts. There is no mass formation at all. So I tell the patient, the reason why I'm doing this is to allay your anxiety and my own, because I know that there is nothing that I can feel, nothing that I can see. All that I'm seeing, this is one of the few conditions that are left in breast where you have to operate basis your clinical understanding, because if there is nipple discharge, if it is bloody or transparent, we have picked up DCIS so many times. So I would say if I were to do 100 nipple discharges, I would be picking up at least 5 DCIS, which is quite a significant number. So we should always do it. Microcalcification without nipple discharge also to be taken seriously. It's not necessary. It depends on where it starts. If the microcalcification is periareolar, there is a chance that it will show up as bloody nipple discharge. But if your microcalcification is in the upper outer or the upper inner or wherever, in one of the distal generations of the duct, you will not be able to pick it up as nipple discharge. So that is a mammographic abnormality, and that is the earliest you can catch cancer. So duct ectasias are a very, very common finding, and I also think, see, duct ectasia is basically a dilatation of the, and usually most women who would have breastfed, their ducts are going to be dilated. You will not see it in that virginal less than a millimeter sized duct. You will always find a 2 millimeter, but once it is 3 millimeters, you start getting worried, ki itna, why is it so full? The thing is, there is going to be some amount of secretion, and sometimes it can get constricted, and once it gets constricted, it will start flowing out of the nipple. So you get duct ectasias all the time.